I thought what we'd do is talk about vertebral artery, so-called vertebral artery testing. Now, I know we talked a bit about the history, but I want to talk about the physical testing. And first off, I think what you should get rid of in your mind is the idea that these tests don't work. More accurately, it's not known how well they work. All right. This is down to researchers and academics saying it hasn't been proved. Well, my response to that is get off your ass and prove it or disprove it, but don't bitch about it. You haven't got anything better to offer. This is what we've got. But I will give you some modifications. And I'll talk to you a bit more about this once we're done. But I haven't got any problem with doing these tests. And my question is, let's say that you do manipulate somebody's neck without testing. And it occurs, all right? You've stroked them out, possibly killed them. And the question comes up, did you test? Now, would you rather say, yes, I did test and the tests were negative, or would you rather say, no, I didn't test because I was told the tests don't work? Which of those two answers would you rather give in court? You know?
I would rather test.
Yeah, me too. Any sensible person would do. Why wouldn't you test? Now, it means that if you get a positive test, you take that seriously. If you get a negative test, it makes you think about whether or not you should be treating this patient. Okay, so the real argument with the researchers is it gives you a false sense of security. And I'm telling you not to have that. All right, a negative test may give you a false sense of security. I think always, whenever you manipulate the neck and the patient comes in the next time and says, my neck is worse than it was, you breathe a huge sigh of relief because at least they're not dead. All right, so whenever you manipulate somebody's neck, it should always be done with a certain amount of fear, just a little bit below the surface. All right. Now, these injuries almost never occur. They're very, very rare. And they're almost all chiropractic, which is understandable for two reasons. One is they do more neck manipulations than anybody else. And the other one is they don't test. So I think if we test and it's positive, great. If it's testing and it's negative, you still have to wonder about whether it truly is negative. Is that okay? So having said that, let's look at some questions on terminology. First off, stop doing whatever it is you're doing as a vertebral artery test. Stop thinking of it as a vertebral artery test, all right? Unless you've changed in your positive. Now, let's say that I produce dizziness during the vertebral artery test. Logically, what's causing that dizziness? Logically.
Lack of blood flow.
Yeah, the vertebral artery. If you're going to call it a vertebral artery test and you have a positive vertebral artery test, the vertebral artery must be the cause of the problem. It's no different from you saying, I'm doing a medial collateral ligament stress test and it's positive, you're going to say it's a medial collateral ligament test. More accurately, what you should be saying is, I'm doing a valgus test, valgus stress test of the knee. And when somebody says, what is it? You say, I don't know. It's one of the valgus stabilizers. All right. So we're going to stop calling it vertebral artery test. So what do we call it? The normal name for this is the decline test, D-E capital K-L-E-Y-N. And this is where you do extension and rotation with the head overhanging the bed. All right. And properly done, there is no support for the neck neither. So basically the head is hanging there. It's also called Wallenberg's test. And actually vertebral-basilar syndrome is also called either lateral medullary syndrome or Wallenberg syndrome. But this, we're going to call it the decline test. We're not going to do that, all right, for a few reasons. First off, if you do the decline test the way it is supposed to be done with the head overhanging the bed, if anything happens, the patient loses consciousness, they start to get nauseated, vertigo, or anything else, you're going to have trouble getting their head back on the bed. All right. So unless you've got a drop down head to the bed where you can just lift them back into a normal position, that's one good reason for not doing it overhanging the end of the bed. It's difficult to get them back. The other thing is the amount of traction being applied to the neck. Now, this can and does cause really nasty vasovagal responses here. It's also putting a stress on the vertebral artery that is unpredictable. You're increasing the tension on the vertebral artery unpredictably. Now, if you do have congenital anomalies in it, so that one artery is smaller than the other, or you have an atretic artery where the artery actually doesn't inject into the posterior inferior cerebellar artery, it goes straight into the basilar. It misses the basilar and goes straight, terminates as a pica. Then obstructing the good artery by stretching is going to create problems for them as well. So that's not necessarily a bad thing. It may show you congenital anomalies, but you have no idea about this. This is putting a lot of tension on a lot of different structures. So we're not going to do that neither, at least not yet. So what we're going to do is, in somebody who has no symptoms at all, but you're doing the test as a precautionary measure, just so you can say it's being done and there was no response to it, which is valuable. It's not just make work, it's valuable to do that. Then we're going to call it a minimized decline test. Okay, so the head now is kept on the bed, it's extended on the bed and then rotated, or you can do all three movements at the same time, but they end up in that declined position, but on the bed. So the head is as fully extended as it would be if it was overhanging the bed. In fact, it may even be more extended, because when you've got them overhanging the bed, if you're using the headboard, you can still you can't push the head under the bed, which you can do if you're using the end of the bed. But if you put them into full extension and then rotation, that's their maximum range of extension and rotation, regardless of where their head is in space. Is that okay? Now, the difference to the balance mechanism in your neck and head is between a minimized decline and a full decline, but with support now. So we've got to take the traction off this, just hold the head so it isn't being tractioned. The difference between those two positions is the position of the labyrinth. And this is a confounding factor. So if the head's hanging below the horizontal, then the vestibular system is much more sensitive than it would be if it was on the bed. So you're now going to confuse the two things. Confuse VBI and a vestibular problem. Were you good so far?
Yeah. So Jim, so they're laying on the bed and you're just kind of putting their head into extension then? Is that, yeah, okay.
Yeah, so extension, rotation, or
Right.
you can do both together. All right.
Okay.
Because you don't know their neck yet, you have no really idea what's happening here. Or you may do. You may be doing this down the road just before you manipulate them. If you're not sure about how the neck's going to react to being moved, then you might be better off doing the movements individually, but you can put them straight in that position. As long as you end in that position, you're going to be in a minimized decline position.
Okay.
Is that all right? The progressive minimized decline position is when you have some concerns. They have headache, they've got dizziness. You're concerned that there may be an issue here. All right, but not concerned enough to say, screw this, I'm not moving them about. All right. You're not going to send them straight to the emergency room. You're not going to call an ambulance. You're just a bit concerned about this. They may be a bit lightheaded sometimes and so on. So now we're going to get them into this position in stages. So the first thing to ask them is, what makes you dizzy as far as your neck's concerned? So if they say, turning my head to the right, you'll start with left rotation. I'm going to go through this on a diagram with you in a second, but you'll start with left rotation. If that's okay, there's no response, no headaches, no dizziness, you can then do left rotation. Okay. If that makes them dizzy, then you can be doing neurological testing at this point. But basically, progressive minimized decline is taking them through the steps to take them to a full minimized decline on the bed, but in stages, so that the first evidence of a problem, you can stop and test those symptoms that they're getting out. Does that make sense? So you get them there gradually. Okay, so that's a progressive minimized decline. Wish I could read my writing. Okay. The Hallpike-Dix test. So let's actually just let me step back a minute. Let's say we've got them all the way through the progressive minimized decline and we've failed to reproduce any of the symptoms that they're complaining of. We can then increase the stress now on the whole system by doing it over the end of the bed. So it's now a full decline, but with the head supported, so you don't do the traction. Now, if that's positive and the minimized decline and the progressive minimized declines on the bed, the endpoint of that is negative, then really what you're left with is this probably being labyrinthine. But that's assuming that the symptom you're trying to reproduce is vertigo. If this is not vertigo, if this is a type 2 dizziness, then you need to be a lot more concerned, because the labyrinth, an acute labyrinthine problem, will produce vertigo. It will produce type 2 dizziness once the vertigo is settled, but the initial onset with acute labyrinthine problems, which is what you'll be dealing here, is vertigo. So if they haven't got vertigo, you're going to be a lot more concerned about what the hell is going on.
So Jim, would you be looking at nystagmus too then?
Well, we'll talk about neurological stuff in a second.
Okay.
But no, you're not actually doing a Hallpike-Dix test. You're doing a Hallpike position.
Right.
All right. And all you're doing now is saying, okay, if that's positive and the other one's not positive and it's for vertigo, this is probably labyrinthine, just simply because of the position of the labyrinth. All right. Sorry, that's the full decline. Now, what the Hallpike-Dix is the full decline test done through range. So they're sitting along the bed, head is rotated, you bring them down reasonably fast but in controlled fashion, so their head is overhanging the end of the bed again. And all you're doing now is, because of the amplitude of movement, you're sensitizing the labyrinth more. It should make no difference at all to the VB system. Now, as far as I'm concerned, once you've got to the minimized decline and you've not reproduced anything, then I think you can turn around and say you're done with your vertebral artery testing, not the vertebral artery test. Because when we talk about vertebral artery testing, this has to include all of the historical subjective stuff we talked about a while back. Is that okay? I did do that with you, didn't I? Associated dizziness and headache, dissociating and so on. So all of that is part of VB testing. And this test is about VB testing, but it's not a VB test. It's like, again, we come back to the knee. I'm doing knee testing. One of those tests is a valgus stress test in the knee. But if I say it's a medial collateral test in the knee, then it's the MCL that logically has to be buggered up. So you have to reverse your thinking all the bloody time. If you're using language right, this becomes a lot simpler. Is that okay? So let's have a look at the diagram. And hang on, I'm going to put glasses on. All right. So what you can see is along that horizontal row there, we've got reproduction tests, differentiation tests, and an action, depending on what you're finding here. So the reproduction tests, basically for our purposes, is this minimize decline all the way down. So as we said, you basically start, if they say they get dizzy with left rotation, you'll start with right rotation. So that's where we'll start now. We start with right rotation. If that's positive, you go on to a cranial nerve exam. You've got to look at the neurological system. All right. If the cranial nerve test is positive, you've got no choice in this, it goes to the MD. Now, your choice, you want to send it to the patient's doctor, which they'll see in a couple of days, or you can send it to the emergency room. And if you send it to the emergency room, you can either send out their car and let them drive to the emergency room, or you can call for an ambulance and get them taken to the emergency room. It's your choice. But for me, now, I haven't got it on there, but you should have already done a cranial nerve exam. So when a cranial nerve exam has been negative, but I make them dizzy, and they also get cranial nerve signs, the test now becomes positive. As far as I'm concerned, that's an unstable cranial nerve syndrome, which is not a good thing, and it should go to the emergency room, and you should not trust them to drive themselves there. Does that make sense? This is like, okay, you've got cranial nerve signs, you've got a brainstem concussion. This is, you didn't have cranial nerve signs, now you do. This is associated with dizziness or headache. During the phase where you didn't have them and you do have them, we've done something to bring them on. So this now becomes an emergency. Even if they go away, this is still an emergency. We good? Now, if we are negative, so right rotation is negative, we can now come and do left rotation. Now, this should make them dizzy if they've said that turning their head to the left makes them dizzy. There are factors that can mitigate this and potentiate it, but normally they should be positive on this one. So you're expecting it and you've got to be careful. Again, if it's positive, you do a cranial nerve exam. If it's negative, we can come down and we can do extension. Yeah, sorry. Those first two tests are done in this order for a reason. There's been different cadaveric studies done on how the vertebral artery occludes. And give me a minute, there's a bang, I'm not sure what it was. Just give me a sec. You okay? I don't know what that was. Sorry. Yeah, there's been some studies done on this. Not big studies, but some. And what they found was that rotation will occlude both arteries, one a lot more than the other. And then which one it is dependent on which study you read, but it doesn't really matter because you don't care which artery it is. But one rotation will occlude the transverse portion of one, and the same rotation will include the craniovertebral portion of the other. So both arteries tend to get occluded, but by different amounts. Extension, on the other hand, will occlude both arteries equally. Now, I would strongly suggest you do one rotation and then move to extension afterwards. Now, if it's the same thing again, you do extension, that's positive, you go through the same system, do a cranial nerve exam and move on. And the same with all of these. So this will take you down through all of these when they're positive. When they're negative, you just keep moving down and you end up at that decline position there. So you've got them, you've fully rotated and extended them on the bed to the right and to the left, and you've failed to reproduce their symptoms. So at this point, you can almost certainly say there isn't a vertebral artery problem with these. So we can move on across and try and differentiate what they are. Now, your first differentiation was a cranial nerve exam. So let's assume the cranial nerve exam was negative. All right, we'll come back to this in a second. Let's assume the cranial nerve exam was negative. We can then move down into these other tests, but they're very much secondary reproduction tests. Body rotation. So we'll say that right rotation made them dizzy. All right. So I want to reproduce right rotation, but without moving the head. So I'll fix the head and have them rotate their trunk to the left. So you still end up with right rotation, but the head's been held still. So if now they get dizzy, you still have to do a cranial nerve exam. But if the cranial nerve exam is negative, you can probably start thinking that this dizziness is due, that was there with rotation of the head and wasn't there with rotation of the trunk. It's probably labyrinthine. Does that make sense to you? You've kept the vestibular apparatus still. Actually, let me be more precise. You've kept the
Could you say that again one more time?
still, and you've rotated the trunk. So if they get dizzy now, it's probably not the labyrinth. If they don't get dizzy now, where they did get dizzy before, it probably is the labyrinth.
Right.
Is that okay?
Yeah.
All right, but either way, every time you make them dizzy, you do a cranial nerve exam. We can keep moving on. A second differentiation test now is Hotard's. Now, Hotard's is done with the arms outstretched in front of you, palms up. They close their eyes, and a full Hotard is rotation and extension. But we're doing this progressively. So whatever position made them dizzy in the reproduction test is the one that you use. And I realize I'm not pointing me fingers at these. Whichever of these tests made them dizzy is the one that you will use for body rotation and Hotard. So if they got dizzy with right rotation, you do right rotation. Is that all right? Now, the positive for this, the true positive for this, is a loss of position sense in the arms or the body. So a minimum one is you'll see the hand starting to supinate, to pronate rather. You'll start just doing this type of thing, wavering. But you can sensitize this by having them touch their nose, touch their fingertip, and so on. Now, whether this is motor or whether this is sensory, I actually don't know. And I don't honestly care very much which one of the two it is. But you're getting fairly hard neurological signs at this point. Now, what you will often see is as they turn their head, the arm position as a thing, you'll see this type of thing happening. That's fairly normal. But you don't want to see actually a change in the rotatory position. This is where it's most sensitive, arms up. If you let them keep their eyes open, they can fix where their hands are. So that's Hotard's. And as I say, you're looking for a positive one of these, and each time you get a positive, you do a cranial nerve exam. And this one, I would suggest, the Hotard does go to the MD anyway. That's a fairly hard neurological study, the same as cranial nerve exam is. Is that okay?
Mm-hmm.
So from here, we've done a full decline. We've gone all through this system, all been negative. We can move on to a Hallpike Dix. And eventually, you may well come to a cause of unknown cause. Now, if this is vertigo, you really need to fire this back, probably to the physician. You've got a hard symptom here that you're not understanding where it's coming from. Now, there are other things you can do at this point because you're not too concerned about vertebral artery at this point. You've pretty much not eliminated it completely, but you're fairly happy. Don't forget where you are at all this. You've taken a history. You've managed to dissociate the headache and the dizziness. You've managed to associate one of these two symptoms to the neck pain. You managed to associate both of them to the neck pain. So every step along the way, the dizziness is not neurological, has no neurological characteristics, and the headaches don't seem to be of neurological origin. So that all of that subject stuff, and then you do these tests that all turn out to be negative, or at least not producing neurological signs or symptoms. How worried are you about this being vertebral artery? So if I get down to these positions here and I'm still not sure what's causing it, it's probably spondylogenic, in which case I can now come on and stress the neck without moving it. I can do transverse shears on this. I can try and do pain provocation, make the neck painful, and see if the dizziness and the headache gets worse when this happens. But I can actually stress test the neck now without moving it. And if that brings on the dizziness, I'm pretty damn sure this is the neck and not neurovascular. Does that make sense? Or do you want me to go over any of this again? No? It isn't the last time I'll be talking to you about this neither. We'll obviously do it again on the call. But are you good for the moment?
Yes.
Okay, so I want to talk to you about sensitizations with these tests. Oh, I forgot the name of it. Oh, did it? He'll come back to me at some point. Go on. There's a sensitization test where essentially what you do is tracking of the eyes during these tests. Now, one of the reasons you need to do sensitizations here is, except for the generation of hard neurological signs is unusual with VBI, especially in transitory types of problems and even early in a stroke. Neurological signs with VBI, or symptoms rather, are rare. So dizziness really isn't a neurological sign unless it's showing neurological characteristics, but straight dizziness doesn't do it for you. And certainly headache isn't neither unless it's showing certain characteristics. So there are sensitizations that will produce neurological signs. Now, one of them is tracking. So while the patient's in these positions, providing they are not dizzy or generating a headache when you want to get them out of that position as quickly as you can, you just have them track your finger. And what you're looking for now is paresis, paralysis, nystagmus even. Okay, because we have no idea if these signs come on before the onset of symptoms or with or after the onset of symptoms. And we have no idea if they do one of those things, but they do them in everybody. So by generating or provoking the sign rather, you're more likely to pick it up than if you don't do that. So just watching for nystagmus, which I think you was alluding to, wasn't it, Kim?
Yeah.
Yeah, watching for nystagmus doesn't do it because neurological nystagmus, for example, is gaze evoked. So if I just have them lay there, they may not get nystagmus, but if I have them track, then you may see the nystagmus kick in when they're tracking. So if you're not tracking, they may not be nystagmatic. Is that right?
Mm-hmm.
So that is, the guy's name completely eludes me at the moment. Anyway, then there's another set of sensitizations called Meadows' sensitizations. And all this really is a matter of bridging the brainstem with these tests. So if you're looking at tracking, you're looking at 2 and 3. 3, 4, and 6. If I look at the pupils, I'm looking at 3. Basically 3. So I can do a consensual reflex test while they're in that position. So I simply cover up one eye, watch this dilate, and then uncover this and watch it constrict, because it will agree with the other one. If it's normal, then do the other one. I can do smile and frown, see if they're losing facial muscles. Not likely with VBI, but you can do it easily enough. You can get them to stick their tongue out and see if you're getting deviation with this. So there's a number of cranial nerve tests you can do very, very quickly while they're in that position. Good. Now, you need a timer. Pretty much any time I've seen these tests become positive, they've become positive very, very quickly, within 10 seconds or less, very quickly. The number that's normally given for maintaining these positions is anywhere between 10 seconds and 60 seconds. I would say that 30 seconds is plenty. So what I do is I'll get them to count backwards. So they are the timer. You get them to count back from 30. And the reason you get them to count back rather than forwards is because now you're looking for language, speech, and voice changes. So you're looking for dysphonia, where the voice becomes hoarse and rasping, or possibly it stops entirely. Aphonia. You're looking for dysarthria, where they start slurring words, or dysphasia, where they're just changing the language. So they can just keep saying the same word, echolalia, same thing over and over again, echolalia, and so on. But you're looking for changes in their ability to communicate. And at the same time, you've got a free timer there. Okay, so these sensitizations can be done during that 30 seconds.
So Jim, are you doing those sensitized tests in that position? Like if the history is really making you suspect there's something vertebral artery going on there, but
no, if I really thought there was something going on with the vertebral artery, I wouldn't do these tests.
Okay, so what would lead you to do the sensitizing test then? Like why are we?
It's just part of doing the test. I would have that as an integral part of doing the test.
Okay.
Simply because you have no idea if you're going to see this. Like if they're laying there and you're not asking them to stick their tongue out, how do you know they got tongue weakness?
Right.
If you're not having to pull faces at you, how do you know they got facial nerve problems? So you have to evoke these signs. You don't do anything different with cranial nerve testing. You can't just stand there and watch them and look for changes. But these evoke those changes, or provoke them, whichever way you look at it. Is that good?
Yep.
Now, for me, a positive declines test that says this is vertebral artery or something worse, and I really can't think of much worse than that, but I'm keeping my options open here, is the onset of neurological signs and symptoms. Now, think about it in these terms. The provocation of dizziness is pretty much 100% sensitive for the vertebral artery. A traumatic vertebral artery has dizziness. If I provoke the dizziness with these, then I can pretty much say that the chances are there's a chance that this is vertebral artery, because this testing is very sensitive for the vertebral artery. But this has always been the argument with these tests. They're not very specific for it. Now, if I get neurological signs and symptoms when I do these tests, or signs or symptoms when I do these tests, then that has to be extremely specific for an unstable neurological or neurovascular condition. I've just provoked brainstem symptoms or signs. Has to be. So if I take those two things together, this is 100%, pretty much 100% sensitive for VBI. The onset of neurological signs and symptoms is 100% sensitive for neurological or neurovascular problems. Then the two together say that if I do these tests and you get neurological signs or neurological symptoms, they have a neurovascular or neurological problem. That's it. You can't argue any other way. The only argument now is, how good are cranial nerve signs? But now this comes to, are they always going to be positive, or are there times when it's negative? And this is what I'm saying to you. If this testing is positive, then it's positive for neurovascular or severe neurological conditions. If it's negative, it probably is negative, very probably is negative for neurovascular and neurological conditions, but you can't be 100% sure. Take all these negative tests, add them to the negative subjective history, and it comes down to this. How comfortable are you now with manipulating these patients? That's it. And if you do techniques that do not displace these joints and the whole neck very much, even somebody with VBI, the chances are you're not going to do damage to the vertebral artery, even if there's a congenital anomaly in there, let alone a traumatic one. And this is where the real problem lies with manipulating the neck. It's really not so much with traumatic necks and the possibility of releasing an embolus, because you've got some indication that that's happening. It's a congenital anomaly in the system. Now, the anomalies that you really have to be careful of, not the ones that are intracranial. You're not going to affect them. You can't change that. You'd have to twist the head itself, not on the neck, but you have to twist one side against the other one, or the top against the bottom. But you're going to have to deform the head to damage any intracranial anomalies. But if they got an extracranial one that is significant, then you start running the problems. So hypoplasia, where one artery is way too small, small enough to not matter, absence of an artery on one side, atresia, where it doesn't inject into the basilar. Now, if you now do a technique that damages a good artery, this person doesn't have a backup from the other side. Now, they've had other backups in there, collateral circulation and so on, but they may not be enough to be able to deal with what you've just done to that artery. And this is where a lot of these problems are found, is it's not that you've damaged one artery, the other one's good. It's that you've damaged one artery and the other one's no bloody good. It's possible that this testing is only possible. It's possible, though, that this testing tests both traumatic artery problems, degenerative artery problems, and congenital anomalies. Maybe, but we don't know. We certainly really don't know about the congenital artery stuff. Simply because if they had a congenital artery and it was that bad, every time they turned their head, they'd get dizzy. But they've got support systems for it already in the form of collateral. So this may or may not do that. So in order to protect a patient with congenital problems in the neck, your technique has to be as minimal. And I'm not talking about force now, I'm talking about amplitude. Your technique has to be as minimal as it can possibly be. Does that make sense? You also need to think about contraindications to doing this test. And the big contraindication really is you think that there is actually a neurovascular problem with these people. So if you've got any concerns about that, we go back to the history. They're giving you a history of neurological dizziness. They're giving you a history of coupled dizziness and headaches that are decoupled from the neck. They're talking about cranial nerve symptoms or long tract symptoms. All of these says do not screw with the neck. And that includes looking at range of motion testing. So if you're seeing any of that, my suggestion strongly is you put them into a hard collar and get them into an ambulance. I had a friend, and again, stop me if I've told you this story. He's a very good therapist in the States. He's a Canadian, but he's in the States now. And he basically stopped manipulating cranial vertebral joints. And simply because of the risk, he figured it was too high. And he may well be right. Anyway, the patient had been seeing a chiropractor for a couple of years, been seeing him 3 times a week for a couple of years. And they'd finally given him up and he'd come to see him. So he said, okay, he said, I'm going to manipulate your neck. The patient was okay with it. He said, I'm going to manipulate your neck. He said, but I'm not going high up. He said, I just don't want to do it. So anyway, he manipulated the patient's neck. Patient went, oh, that feels much, much better. He said, oh, good. He said, okay, let's just look at your range of motion. Turn your head to the right. And the guy went, oh, God. And he was dizzy and nauseous and all sorts of stuff. So he actually drove him to his family practitioner. Family practitioner went, he said, I don't like that much. So there was an imaging clinic right next door. So he said, let's get you in there. And they imaged him, and actually he damaged one of the craniovertebral joints, one of the craniovertebral part of the artery. And when everybody sat down and figured out afterwards, they figured that actually what it was the chiropractor damaged it, because the patient did have a lot more pain after the last chiropractic treatment they went to. The chiropractor probably damaged it. He's got the lower neck working and got rid of a lot of the pain, which allowed the patient to move their craniovertebral joints more, and boom, it was an embolus. So this went all over the place, and he was found not to have actually caused the problem in the neck and the craniovertebral joints because he didn't touch craniovertebral joints. But this is one case where it goes wrong. I wouldn't have done that. I wouldn't have driven him to his doctor. If I was going to drive him anywhere, I'd drive him to the emergency room. Because now you're taking one doctor, he got in there fairly quick, but you're taking one doctor, then to the imaging, and then to the emergency room, whereas in the ER is basically a one-stop all-service centre. I don't think you can be too careful with the crowd. It doesn't pay to be sort of casual about this stuff. The numbers of, as far as how many systems are damaged by cervical manipulation are not well known. They vary anywhere from none in 13 million manips all the way down to 1 in 5,000 manips, which is completely and unacceptably high if that's the case. But that was done in California as a survey by physicians on their patients, and it turns out the same patient was counted by about 6 different practitioners, by the physician, by the ER registrar, the attendant, and so on. This is done by the, so they were getting about 6 reports on each individual patient, so they weren't very good. Possibly one of the better ones was a Swiss study that reckoned about 1 in 40,000 manipulations cause a problem. I maintain that if you listen to the patient properly, do some reasonable testing, and do techniques that do not stress the artery too much, the chances are you're never going to have a problem with this. Okay. I am not going to teach craniovertebral manips on this course. All right. Actually, you can adopt some of these to the craniovertebral joints. The reason I'm not doing it on this course is because I think you need to manipulate the neck a few times before you even look at the craniovertebral joints. So there's an advanced course where I do teach, and I really should run one. I haven't done one for years. There is an advanced course where I will do these techniques, but I won't show them on this course. All right, carry on mobilizing. You don't need the extra headache of being that risky when your techniques are still not that great. All right. Is there anything else you want me to talk about there? No? Sure. Okay. All right. Don't think I've got anything to add at the moment on that. Give me a minute. Okay, let's do this. This won't take long. Where's my Zoom gone? All right, I'm going to talk to you about essential illness scripts. I'll find them again. Yeah, there we go. All right. So this is, we've talked on and off and on about this, but I thought I'd hit this again. It won't hurt. This is when you're not an expert with a particular condition. I've used tennis elbow over and over again on these discussions simply because it's easy enough to be an expert on tennis elbow, and you can use pattern recognition. These are the times when pattern recognition is failing you because you haven't got enough experience with a particular condition. So you make your first hypothesis, H1, on the first symptom you're given. So let's say we're talking about, doesn't really matter, medial knee pain. And that's my hypothesis. I then generate an essential illness script. Now, this is maybe 3 or 4 questions, couple of tests that are specific to that condition that will describe the average condition that you're hypothesizing. So let's say it's the MCL. So first off, medial knee pain. Well, you've got that, and that's what you based the hypothesis on. You then think, okay, what's the illness script for this? Well, first off, the ligament's going to be tender. So we'll palpate. It's tender. Second thing, what is it? Okay, stress test should be positive. You stress test it, that's positive. All right. Now, given those 2 things, what else could this be other than an MCL tear? Any thoughts? Or would you say you've proven that this is an MCL tear? Feedback, please.
I would say that you've done a decent job of proving it's an MCL tear.
Yeah. 2 tests, basically 2 questions. Well, 1 question, 2 tests. Where's your pain? Should be tender, and it is. Stress test should be positive, and it is. And now, when I say positive, it doesn't have to be unstable. It needs to reproduce the patient's pain. It can be unstable, but if it doesn't reproduce the pain, then I am less happy with saying I've proven the MCL. Is that okay?
Yeah.
They may have an MCL tear, but I can't guarantee that's where the pain is coming from. Does anybody have a different thought on that?
No.
Everybody happy with it? All right, I'm going to assume that I'm not hearing from you agree with it. So now we do need to say that we may have bias involved here, and I may have made an error. So we can come into bias and error correction at the moment. I'm not saying this is your diagnosis. I'm saying this is a very strong hypothesis.
Mm-hmm.
Given that I can make a mistake, I mean, I don't, but other people do. Given that I can make a mistake, I can be wrong. So now the bias is, first one is, I haven't done a good enough exam. There may be another problem. Maybe when the MCL tore, they also tore the meniscus. Maybe they also tore the ACL. So I look at those 2 and I do differential diagnosis. What else could this be? What else could be with it, even if I've proved it? So now I can come in and start palpating not the ligament, but deeper. Now you've got a problem when you're trying to palpate a deeper structure, because you have to palpate the overlying structure. But if I push in deeper, the tenderness should not increase exponentially. So while the ligament might be tender, if I now hit the tendon meniscus, you should get a sudden increase in more pain. You can't do the ACL, but I can do a stress test for the ACL and see if that's painful as well. So I can work on this. I can complete the exam, don't have to be the entire exam, and I can do differential diagnosis and test each one of those differentials out with 1 or 2 tests and questions. So now if the bias error correction is good, then I've got H1 transformed into DX, the diagnosis, at least in a working fashion. I can now take that diagnosis and plan a treatment around it. Yeah. The final confirmation that the diagnosis is right from a clinical perspective, from our perspective, is that your treatment works. If the treatment doesn't work, we are into the realm of this. We have to revisit the diagnosis, the entire thing. I've treated you 3 times, nothing's changed. We need to go back and see what I've screwed up here. So you revisit the diagram, which means re-examining it, and you may want to get a second opinion if you're not happy with that. And especially you want to get a second opinion if your diagnosis comes up with the same diagnosis your first exam did. Don't be afraid to get a second opinion. Okay, now if your H1 is disproven, you move on to H2 and test with EIS2. Now, you just don't pluck a hypothesis out of the air as you did the first one. Well, it wasn't out of the air, you base it on a symptom. You're now going to base it on the test you did for H1, positive and negative. Well, I know it's not the MCL because those were negative, but what was positive? Well, let's palpate in deeper. Let's see if the meniscus, because it wasn't tender on palpation, let's push into the meniscus. Oh, that hurts them. So now your tests for this would be meniscal tests, looking for the reproduction of pain and maybe clicking. Yeah, and so on. So again, if that's proven, you go into your bias and error correction and so on. If it's negative, then you come down H3 and test with EIS3. Now look at every time you regenerate the hypothesis, you are getting more information. You've discarded hypothesis, you're bringing in new ones. So every time you basically come up with a new hypothesis, the chances are that hypothesis is going to be more accurate than the first one was, or the one that preceding it was. Okay, if this is disproven, you move into HN hypothesis N, whatever it is, 4, 10, or whatever it is, and you keep going until you either say, I have no idea what the hell this is all about, or you say, got it. Okay, so this isn't about failing. You didn't fail, the hypothesis failed, so you come up with another one. You haven't failed anywhere. You haven't done anything that would lead you to think you did fail. Simply because you haven't done anything. How can it be a failure when you haven't done anything? Failure is when you do something, the patient doesn't get better, or the patient gets worse. But you haven't done anything until you come up with that last diagnosis. Now, if you treat that and it doesn't work, then somewhere along the line you failed and you have to correct that failure. Otherwise, all you're doing is discarding hypotheses. The only difficulty with this system, and this is basically hypothetic deduction, or more accurately, hypothetic abduction. The only problem with this system, where script focused hypothetic abduction is a subset of hypothetic abduction, is your ability to overcome previous conditioning. There are 2 things that you don't like to do. One is make a hypothesis on minimal information. I need more information. It's all I ever hear from people in classes. I've got to have more information before I can do that, which is bullshit, and I'll tell you why in a second. And secondly, changing the hypothesis when it proves, when you have a better fit, which is what it's all about, is getting a better fit for the information you're getting. So they're the only 2 reasons that this fails with people. It's not the system itself, it's a failure to comply with the system and do what you've got to do. The fact of the matter is, let me give you an example. I have a patient with pain on the underside of the heel. I do not want you to produce a hypothesis. What are you thinking right now? Come on. Kim, what are you thinking?
I'm
Truly.
not supposed to come up with a hypothesis.
No, I don't want you to think of a hypothesis. So what are you thinking right now?
Well, if I can't come up with a hypothesis, I'd like to go in and just feel like
No, I'm asking you not to think of a hypothesis. Are you thinking of a hypothesis right now?
I am.
Of course you are. Exactly. If I say don't think of an elephant, what's the first thing that comes into your mind?
Think about it.
Controversial.
Like the elephant. You cannot not think of a hypothesis. It's ridiculous to think that you can. Absolutely. Like as soon as you see or hear something, you start making judgments about it. What you're trying to tell me when you say I need more information is you don't do that. And I know damn well you do. You're human. You can't help but do that. So go with it. That's what you want to do. Go with it. So you make your hypothesis and you test it. Changing the hypothesis, people think it's a failure, and it's really not. It's a part of a process. You have a process that you're using. Changing hypothesis is part of that process. It's a routine part of the hypothesis. I don't understand the problem with this. I do not understand students, is basically what it comes down to. I really don't. Now, I can understand it amongst experts because experts think they're infallible. So they'll go pattern recognition. I know what that is. I've seen it 100 times, and they're wrong, and they will not change it. After about 10 treatments, they'll go, all right, let's change the diagnosis. But it takes a lot for an expert to change their opinion simply because they're an expert. So I understand experts not changing their opinion. I do not understand non-experts not changing their opinion. Anyway, now it makes sense that your hypothesis would be the most probable hypothesis. That would make sense. It's more efficient. However, if in amongst the differentials for a particular condition is something serious but unlikely, like VBI, I have a patient coming with a headache and dizziness, the chance of that being VBI is almost zero. But it isn't zero. So if I've got something that is particularly dangerous, I will make that the hypothesis and disprove it, hopefully. If I don't do that, then I'll say, in my back of my head, I'm going to say, well, that doesn't matter because it never happens. Which logically would be ridiculous because it does happen, otherwise you wouldn't be thinking about it. I'm not going to worry about that because it never happens. So I'm going to concentrate on this because this is more likely what it is. And you'll end up proving that and not looking at the other thing. So this brings in anchoring and all sorts of other biases. When it's a serious possibility, you go that way first, disprove it, and you can do everything else comfortably at that point. Whereas always in the back of your mind, that's going to be twigging at you. Okay. So try it for me, all right? It's really a cut down, well, it's not a cut down version of pattern recognition. It mimics pattern recognition. And as I said to you before, I think schools teach you not to be an expert because they're teaching you to do the exact things that experts don't do. Gather all the information in before you make a decision, and no expert does that. And you're all pattern recognition experts. Humans are. You make patterns even when patterns don't exist. You're pattern recognition generators. It's what you do. It's what you've been involved to do, and you could not function if you didn't do that. So your natural tendency is move towards patterns. So why not encourage it, formalize it, and give you corrections that you can do to stop going overboard with it. Okay. All right. For next week, does anybody have any sort of wants, desires, fears, blank areas, ignorance areas, anything you like that you want me to do, email me. All right. I'll get you the dates as soon as I've got them confirmed by the clinic for the Edmonton course. And hopefully you can make it. If not, we'll try and do something. I'll try and work something out with you. If you really can't do it, but you're going to have to go to Calgary and I'll have to sort something out with you on that. All right. But hopefully you'll be okay with it. Really, my concern is not with you lot. I'm not that concerned about getting the disease myself. But if I have to quarantine myself and I miss 1 or 2 weekends, we're screwed. We'll have to reproduce the whole bloody course all over again. And I can't charge you a second time. So when we do it again, you will suffer immeasurably. All right. But let's say we do. Oh, I know what. Do you know anybody know if there's a physical therapy alumni chat room or anything for U of A grads? There's going to be a whole bunch of new grads coming. They're doing the licensing exams in March. So I've got a feeling there's going to be a lot of people who want to do this class.
I know someone who is actually going for the exam in March. I can check with her.
Could you see if they do have some sort of communication thing?
I think they have, based on what I know from her in the EOA grads, they have some sort of a,
Okay, because I'd like to get word out there.
Yeah.
I really feel bad for these kids. I think that's what they do.
Oh yeah.
That's
Terrible.
it's terrible. And they're
money, for Christ's sake, not this.
yeah.
It's really horrible.
So what do you want me to pass it on, Jim?
I'll tell her that I'm going to be looking at some classes in the 2022.
Okay.
And I'd like to get the information to that group.
If you can pass it on to me, I can send it to her too.
Okay.
Big deal.
All right, good.
I can ask her to send it.
All right, lovely. Thank you. Otherwise, I'll see you next week. If you've got anything you want me to talk about, let me know. And what will I talk about next week? I don't know. You'll find out when I see you. All right.
Okay, thanks, Jim.
All right, guys.
Thanks, Jim.
Have a good week.
Thanks, Jim.
Bye.
Have a good week.